And we're now going to start the second part of our webinar. And you're going to hear a little bit more about the journey that PPE takes from where it is manufactured to where it actually gets used. And even before that journey starts, you need to start with advocacy. You need to start with very clear messages regarding policy and advocacy and funding. This is an exciting topic, and we've got three wonderful speakers. Again, I'm delighted to introduce Dr. Madeline Ballard, who is the Executive Director of the Community Health Impact Coalition, Andrew Mccalla, who is Vice President, Emergency Response and New Initiatives at Direct Relief, and last but not least, Tapiwa, whom many of you know, who is the Director of Supply Chain at Village Reach. Madeline's going to speak briefly about the role that SHEIC has played, Community Health Impact Coalition has played, and the voice that she has provided along with others to prioritizing the needs of community health workers and to protect them. Andrew's then going to take us through the journey from factories to getting the PPE in country, and then finally Tapiwa was going to talk about being the connective tissue, he and his team about being the connective tissue between the supplies coming into national capitals and then all of the efforts it takes to actually get them to the last mile and all the challenges that are faced within that. So with that, we're going to start with Madeline. And Madeline, you were one of the earliest voices to highlight the importance of protecting community health workers in the context of COVID-19 so that they could both continue to provide essential health services as well as protect themselves, which is, of course, incredibly important from an ethical standpoint. So we'd love to hear from you what key messages you emphasized at the start of the pandemic and how that journey has been, what messages got listened to, which ones didn't. So over to you.
Sure, thanks so much, Krishna. So just to briefly recap, because Gabrielle gave such a great overview of the situation as it was last March and continues to be in many ways today. And then James added that color sort of from the front lines of providing care. Basically, what we realized, and I should say I'm speaking on behalf, not of myself, but of the Community Health Impact Coalition, which is a team of practitioners working in over 40 countries who've come together to make professionalized community health workers a norm worldwide, which is to say paid, adequately equipped, adequately supplied, because too often that's not the case. So what we quickly realized at the beginning of the pandemic was that we were facing this triple burden. There was an absolute shortage of PPE in the world. There was a large geographic and intra-cadre disparities in that, as was mentioned, a lot of low and middle income countries were not getting quite the access that high income countries were, to put it politely. And then even when PPE did make its way to many of these countries, CHWs were last in line. And I think this reflects existing ideas about their worth as healthcare providers, which again are not borne out by the evidence. We know that community health workers are essential to providing and maintaining key health services, everything from malaria testing to vaccination to malnutrition case management with mock tapes, like Freddie mentioned. And then again, we're taking on these new roles in COVID-19, case finding, in Kenya, home-based care provision for COVID patients. And it's really worth re-emphasizing, as James did, that none of these services can be done over the phone from 6 feet away or with only a homemade mask. And in the absence of PPE, as was explained, these services were stopped. Or we saw community health workers being asked to work without protection, which again puts themselves at risk, puts their families at risk, and basically presents the situation where, as they go house to house to house, they can become virus transmitters rather than agents of healing, which is, ultimately what they can become, but only if they're well supported. So you saw in the video, this is what I shared. It's so simple. Again, I think there are so few silver bullet, quote unquote, interventions within the global health space. This comes pretty close without PPE, CHWs cannot maintain essential services, which again often kill more people. The disruption of which often kill more people in pandemics than the pandemic itself. They can't take on these additional roles for COVID. They cannot protect the most vulnerable. And so the first thing we did is, in collaboration with CHAP and the Center for Global Development, we quantified the problem. We tried to validate the annual PPE needs to protect an estimated 900K CHWs in more than 20 countries across the continent, which and that represents about 40% of the population of Africa. What would it take to protect them? And we estimated that these CHWs would need approximately 440 million pieces of PPE to protect themselves and their communities while maintaining this essential services over the course of the year. And this is really critical because we didn't just kind of go and do this off in the lab. Because we had this network of health practitioners working in so many countries with ministries of health, they were able to work together with us to quickly validate those estimates, because they knew that as soon as these counts, again long overdue, were done, they would immediately be put to work in requisition forms to secure the donated PPE. And this might sound strange to folks, like why don't we know how many CHWs there are in countries? But I think this is one of the inequities that COVID has highlighted, that again, because so often these health workers are treated as sort of informal cadres, suddenly when it comes time to needing to protect them and engage them, we don't know who they are, where they are, or how many there are. And so that was definitely step one. And it allows us to make these key recommendations. One, that countries need to use these numbers to make sure that CHWs were included in national PPE supply chain plans, not just for this requisition through CAF-Africa, but moving forward, other sources. Again, I think CAF-Africa was one of the 5 largest procurers of PPE in 2020, but 400 million, and that's just for CHWs. You need a lot of actors in this space, and there were other actors. And so we were trying to change how all of that was done. That we deploy PPE for CHWs alongside pay, training, supportive supervision, all the things that they need to reduce stigma, and that we investigate opportunities for domestic and regional manufacturing, which I think you'll hear more about from our other partners. So those were some of the key things that came out of that early part of the pandemic.
Thanks so much, Madeline, for taking us through that part of the journey. And it's really interesting that this is a journey that we seem to take as the global public health and supply chain community over and over and over again. I think one of the potential positive outcomes of a global pandemic of this size and scope is that it really has gotten the attention of the entire planet. It's tragic that it took so much to focus in on frontline workers, community health workers in particular. But just looking at, you touched on a few points. Only 14% of community health workers, I understand, are actually salaried. The vast majority of them are volunteers and receive intermittent stipends. So that's a really important point as well. And we need to stop making excuses, is what I'm hearing. And we now have estimates, we now have evidence, we now know what is taken. And I think what was really striking to me was that that what is needed from the quantification exercise that you and others did with the Center for Global Development, my understanding is what's needed to cover most African CHWs is $100 million of PPE a year. And I think that really sticks with me, and I hope it'll stick with the audience and spur us to action to make sure that this is the last time we need to discuss things like this, and actually be better prepared the next time. So with that, I'm going to transition to Andrew Mccalla, who is leading direct relief's efforts for purchasing as well as procurement, and he's going to walk us through this really exciting journey of massive supply chain procurement in record time. As a supply chain practitioner, I was blown away by how quickly you mobilized, how rapidly you were able to get commodities in country and start to distribute. So over to you to share that part of the story of the journey. Thank you.
Thanks, Krishna. And I think, you know, what was so great just to start with about this partnership was that this massive partnership was that it leveraged everyone's strengths quite well, as you said. So, you know, direct relief supports CHWs all over the world, including in the US. We know they're always the last in line for supply, but you know, we've supported CHWs in Africa for many years, but there's no way that we would have had the ability to do the quantification work that Madeline and the team described. So once we had those numbers, we could go and do what direct relief does best, which is sourcing the commodities that are needed at the highest quality and get them to partners at the lowest cost. But as everyone might remember, back in April of last year, a year ago, there was a global shortage of PPE. Everyone in the world needed the exact same thing at the exact same time. Countries were bidding against each other, like cities and states were bidding against each other. I live in Los Angeles. I remember the mayor of Los Angeles was bidding against the governor of California. So it was really hard to get the supplies you needed. Prices were going up. That led to bad actors in the system, counterfeit products. Defense Production Act was enacted so that U.S. suppliers, we couldn't buy from U.S. suppliers for export. Indian and European manufacturers weren't exporting anything. So the supply challenge was very real. So we started a pretty rigorous procurement effort to overcome these challenges. And it's not something we actually do. Direct Relief donates about $2.8 billion worth of medicine every year. Most of that is donated. So we aren't actually typically a big buyer. But what we had was, we had these very real numbers, a very real need. We had the availability of cash. And because we're able to pool this large, extremely large need, we were able to find relationships, develop relationships directly with manufacturers, mostly in China at this time, who would actually take our order because we had cash on hand and a large need. And then we had a team that could vet those supplies in China before we needed to ship them. We didn't go through brokers. And we were able to then also bring the cost down from then till now by about 60% from what the prices started out at. So in the end, we were able to source, procure about the equivalent of 89 747s worth of supply, about almost 3,000 pallets from about 7 different countries. About 500 tons of product supplies in total. A lot of those numbers don't mean much to anyone. 500 tons is the equivalent of 3 statues of Liberty as a way to think about what that is. But then we needed to get that all to these 18 countries in Africa. And that was not only a huge logistical challenge, but it was a very high cost associated with that. We wanted to get it there fast, so we didn't want to use ocean freight containers. We wanted to fly it, and that's where the World Food Program came in. It truly saved the day. We're offering a free-to-user service for PPE. We became their 3rd largest user of that service globally, out of 70 organizations, just after UNICEF and the WHO. And they transported it all for free, saving us, the initiative, millions of dollars, which we could then put into more supplies for community health workers. And I can't say enough about how incredible that was and that offering. And then the last thing I would say is we were always looking to see, can we get any of this locally? Can we support local manufacturing in these countries? Always had an eye on that. We were able to, by the end, early 2021, able to make purchases directly in Kenya and Ethiopia from local suppliers, manufacturers, to support those local efforts, as well as reduce transport costs after WFP stopped those services. So I think I will stop there.
Thank you, Andrew. Just one last thing before we switch to Tapiwa and hear about sort of, how then the PPE got distributed in country. Can you share maybe just as an approximate percentage, because we do want to respect any confidentiality agreements with manufacturers, what the impact of pool procurement was in saving resources and allowing you to then buy even more PPE?
Yeah, for the commodities we purchased, we were able to, with the pooled and the volume, we were able to bring the face shields down by about 30% and the face masks down by about 60% in the end.
Wow, that's really impressive. And I know that as both of you have been talking, we've been getting a lot of requests in the chat for the figures that Madeline and I mentioned. This is actually collaboration with Prashant Yadav and others at the Center for Global Development. You'll hear from Prashant in a bit, and we will send that out to participants as a follow-up. So thank you so much, Andrew, for sharing and bringing that alive. Was it 89 jumbo jets? Wow. And so Tapiwa, you received these 89 jumbo jets worth of commodities, and you're helping countries plan to then distribute them with over 30 organizations, many of whom are on the call today, on this webinar today. And can you describe what that was like and what challenges you faced, what wins you had, and what gaps remain?
Thanks, Krishna. I want to start by recognizing that even though this was an emergency, our logistic goal was to ensure an uninterrupted flow of PPE from the points of origin, which Andrew has mentioned was in China, in Malaysia, all over the world, into the hands of community health workers. We didn't deliver commodities to the airports and considered ourselves delivered. No, we considered ourselves to have delivered once we got the PPE into the hands of the community health workers. And this whole process started with us, like Madeline pointed out, quantifying the needs, determining what the gap was, and this informed the orders that we were able to place with direct relief for the commodities to be delivered to particular countries. This process, I'm happy to say, resulted in us creating some global goods, some tools that are reusable in this emergency and into future emergencies. We have a quantification tool which is available on the Village side, on the CAF-Africa website. We have a gap analysis tool. Look, the gap analysis tool is important to us because we wanted to ensure that we were not duplicative to what other partners, Andrew mentioned that WHO, UNICEF, Global Fund, were also procuring PPE, and we did not want to duplicate that. So we developed a tool that allows us to pick out what the gap was, and we delivered this gap. So this initiative was really additive in that regard. Delivering PPE to 18 countries in an environment in which we have airport closures, flight cancellations, is a very daunting task. It's extremely difficult. But it is even more difficult to deliver PPE in extremely hard to reach areas. No roads, sometimes we had to use canoe, and we had to deliver PPE to close to 500,000 service delivery points who are our community health workers. The constraints were many. We have constraints at the airport, customs clearance. In some countries, the procedures were changing as they were equipping themselves for the emergency response. Look, in Angola, for instance, it took, once the items arrived at the airport, it took over 60 days to get the commodities out of the airport because of customs clearance, red tape, and bureaucracy, and we had to manage that. The PPE is extremely bulky. The storage requirements are for routine environments, and so we overwhelmed the redundancy that systems have. We had to leverage on other sources of storage space. The transportation capacity, it can only be designed to cater for a certain volume of commodities. And again, PPE is bulky, 7 jumbo jets to 18 countries. Some is a very huge consignment to receive. Given that this was an emergency, of course, it costs more to deliver commodities to the last mile, and a lot of our countries that we supported in constraints in the last mile delivery budgets. And so we had to think creatively about how we could cross that bottleneck. But to overcome these bottlenecks, we optimized on synergies with government, with the private sector, with the NGOs and other stakeholders operating in the countries. And I want to say the key success factors that saw us overcome these constraints were we had the Ministry of Health being at the center and at the front of the initiative. This allowed us to receive customs waivers, duty-free certificates to be able to bring in the PPE, which Direct Relief was able to source at low cost and ensure that it even arrived at an even lower cost because we did not pay customs duty for these. Because this initiative involved 18 governments, over 30 community health organizations, and many supporters, we had to develop MOUs that helped us assign roles and responsibilities, ensure that there was accountability, and it was clear the role that each of the stakeholders was to play in this. Another key success factor was that we understood that there was a surge in logisticians, there was a surge in the number of people that were involved in the logistic process, and we had to deploy rapid training, focusing on commodity handling, pre-planning for receiving, pre-planning for storage and transportation, last mile distribution, and of course, being accountable for the supplies that were being delivered. And we also recognized that even though this was an emergency, sometimes in an emergency, you focus on implementing things on a no regrets basis. But like Dr. Morini has indicated, on the supply chain, we've seen some system strengthening benefits coming out of how we implemented this initiative. For instance, there have been policy changes. We are beginning to see the needs for community health workers being included in the national forecasts. And this is going to happen in perpetuity. This is going to continue. It has resulted in us understanding and knowing the full need for community health workers. So Krishna, I'm happy that through this, we have been able to drive and influence change in how supplies are planned for community health workers.
Thank you so much, Shabiba. What a great note to end on. So just to summarize, hearing from Madeline, Andrew, and Tapiwa, I think we heard the importance of quantification tools. They exist, so we should be using them. We have working estimates of what it costs to provide protection to community health workers who are providing, as I understand, essential health services to about 40% of the population in the 24 countries that the CAF-Africa team originally scoped out. So that's a large part of health coverage. In terms of being able to rapidly mobilize, working with direct relief, existing relationships, having cash on hand, and pool procurement were critical success factors. And it was really remarkable to see how critically important the World Food Programme's support was in making it all happen. We know that there were many other players behind the scenes in the WFP free-to-user service. But we all recognize how important that was. We've heard some really important constraints from a supply chain and logistics standpoint, but I do want to underscore as we transition to the future that there are also some important systems level constraints that do need to be addressed in a serious manner. These include for community health workers, protecting them in future. It shouldn't be an option, it is necessary. Professionalization pathways that I know the CHW community has long been advocating for, and remunerating them fairly. As I do a lot of work in gender and health as well, and just wanted to also add that about 70% of frontline workers across the globe are women. I think it also becomes a really important gender equality issue for us to grapple with and to actually do something about.